Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Monzur Morshed. He's a cardiologist, and today's Kevin MD article is Why South Asians in the U.S. Face a Silent Heart Disease Crisis. Monzur, welcome to the show.
Thank you. Thank you, Dr. Kevin, for having me. It's truly a privilege to be here.
All right. Thank you so much for writing and joining us. Tell us a little bit about your story and then the Kevin MD article that you shared with us today.
Okay, I am a board certified cardiologist practicing in New York. I'm originally from Bangladesh and have served a very diverse patient population. For example, immigrants, working class men, families under stress for decades now. And during COVID, I did a lot of community education, including through Bangladeshi television like Time Television, TVN 24, IBTV, and also public health outreach in underserved areas. So I came with the article because when I see my patient and where I practice right now in the Bronx and especially South Asian community, and they have hypertension, palpitation, chest pain.
Mm-hmm.
But when I see they have, sometimes they don't have any other risk factor that we look for. But however, they are diagnosed with a lot of heart attacks, and even though they don't have traditional cardiac risk factors, they're too young, too thin, too quiet. So then I thought that, let me see, I can write something about it. And then right away, I thought about your podcast and your journal, which is very popular and very reliable. And I know when I was a medical student, I used to read your articles sometime whenever I have time. So that's the way that I came, to come to your podcast today to talk about that.
So let's jump straight into that article, and you highlight that some South Asian groups develop heart disease 5 to 10 years earlier than other groups. So talk about that genetic predisposition.
Yes, you're absolutely right, Dr. Kevin. South Asian are very vulnerable to have some genetic and biological factors like insulin resistance and central obesity, even though they have normal BMI. But many South Asian have visceral fat, thin outside but fat inside.
Mm-hmm.
And also they have dyslipidemia. They might have low HDL, high triglyceride, but quote unquote normal bad cholesterol like LDL. And also, recently, we are talking about lipoprotein small a, and South Asian are more like to have higher lipoprotein A because it's a genetically determined and associated with early atherosclerosis. They have a higher prevalence of diabetes and metabolic disease, even though they have lower BMI because of the central obesity. They have high sensitivity CRP, which is a very pro-inflammatory marker. And also, Dr. Kevin, that South Asian, they love rice, but they love high carbohydrate, refined grain, sugary diet. So white rice, sweets, that also can be, contributory, to increase the metabolic disorder. And since they are cooking a lot of traditional oil cooking, and they use trans fat, and that also can contribute to have very abnormal cholesterol. The way they have the lifestyle, most of them have low physical activity. They don't like to go to gym. However, they probably use some tobacco. Maybe they don't use tobacco, but this is the biggest thing that I want to emphasize is the psychosocial stress.
Mm-hmm.
Having an immigrant family, and they constantly consider about, whether or not they will be deported or not. They're having a stress in the family, and sometimes they go through a lot of stress like, divorce, not having good job, where society does not acknowledge them as much as it should be. So all this stress means cortisol increase, Dr. Kevin,
Mm-hmm.
and that cortisol is just another vicious cycle that, stays in our system. And eventually that's chronic inflammatory system, kick in. So then we get early aggressive atherosclerosis. And bottom line is, even though they look thin, even though maybe they don't smoke, even though maybe they have quote unquote normal LDL, but the genetic, biological marker, under stress, all these things can lead to early heart disease.
So several things that you said that got my attention. So you talk about the high visceral fat. So sometimes a normal body mass index can be misleading for South Asian patients. And then sometimes in your article, you also note that South Asians sometimes have a vegetarian diet, but because of these genetic factors that you talked about, you call
Right.
that a dietary illusion for many South Asians, right?
Yes.
Now, you also talk about lipoprotein A, and we've talked about that sometimes on my podcast. And like you said, it's genetic predisposition for atherosclerotic risk factors going forward. To my knowledge, there isn't really any treatment specifically to lower lipoprotein A. Is that correct from your understanding?
Yes, yes, very beautiful question, Dr. Kevin. And since lipoprotein A, almost 90% or plus minus little bit, genetically determined, so you know that your typical statin therapy, like atorvastatin or rosuvastatin, probably not going to play that much role. In that case, so we cannot change our age. We cannot change our genetic component. However, if we get the early determination, like let's say you screen somebody with lipoprotein A at least once in their lifetime, and you know that where is the status of that patient is. So we can do other component outside of our environment, like what we can do. And plus, we can do maybe something PCSK9 inhibitor. Dr. Kevin, nowadays, Pecirin or Repatha or those injection type of medication also play a significant role, especially for this type of patient.
Now, in terms of screening, like you said, that you have a large immigrant population, what role do you use lipoprotein A to screen? Do you have any clinical symptoms that point you towards lipoprotein A? Do you just simply screen everybody for as a cardiologist? So, what's your triggers for ordering that test?
Right. Again, that's a very beautiful question. Typically, that we order some of the tests, like typical lipid panel and all this, and then we plug in the number in the ASCVD calculation, and you know, less than 5% is the very lower sense of having a cardiac disease. And then right after 5, and then about 7.9, or those are the, typical number for regular typical American. You probably, if you don't have a family history of any heart disease, probably you can manage that with diet and lifestyle modification. However, South Asian, I think, with this number, even though considered normal in Western medicine, but I think they should have lipoprotein A screening at least in their lifetime to see whether or not they are carrying any significant risk to having heart disease at future. So that way we can do some other tests like coronary calcium scoring for this type of borderline risk type of patient or South Asian patient. They should have this type of screening so that we can diagnose early.
So you have the basic lipid profile, and then you plug it into the 10-year cardiovascular risk calculator. If you get
Mhm.
a borderline result, like you said, between 5 and 7.9% in a South Asian patient, then you would do a lipoprotein A to look if there's any genetic predisposition for coronary vascular disease. And then if it is elevated, then you could look at these specific tests like the coronary artery calcium score. Am I getting that right?
Exactly, Dr. Kevin. Yes.
And then in terms of age, like in terms of how they can present with coronary artery disease, are we seeing people being diagnosed at a younger than normal age? Like what kind of ages are we talking about here?
So in my clinic practice, I see that people who are like around 35 years of age, 40 years old, with no other risk factor, is still they end up with CABG, bypass surgery. So just giving you one example, like that. I see another patient having nothing, but they are so afraid to talk about when I try to dig into more into his history. And then I found out that he's a very educated person, but he has a tremendous fear that his wife gonna leave him. So he's getting a lot of stress from his divorce. And eventually he ended up with just quote unquote acute heart attack. And then we found out that Takotsubo cardiomyopathy, which Dr. Kevin, this is a stress-related cardiomyopathy, symptom exactly just like heart attack, but in the cath lab, everything is normal, especially coronary vessel. So those are the things that I see that at young age, they are getting, a lot of cardiac issues.
So you mentioned that psychosocial stressors, especially in that immigrant population. Now you're a cardiologist. Now, how do you address those social factors for some of the patients who come see you in your cardiology clinic?
So whatever is normal, quote unquote, and I still try to dig into more history, whether or not they are having any other issues, whether or not they have a family history. And a lot of them, they don't even know because it's a sudden cardiac death, especially back in Bangladesh. Most of them could not even make it to coming to even hospital. And and after that, they probably don't know. So whenever patient comes to me, I try to, just screen just like typical American, and then I try to go through little bit more, like where they stand in our chart ASCVD, where is their BMI, even though BMI is normal in American culture, what you consider normal, but in their normal doesn't mean that it could be normal. So those are the things that I need to, focus more so that I can screen more in details whether or not they will have heart disease at future.
As you know, there are so many tests where we could indirectly measure coronary artery disease. You mentioned a coronary artery calcium score. So, why choose that test versus, say, imaging stress tests, nuclear stress tests, exercise stress tests? So, take us through that decision process with someone without any symptoms, has an elevated lipoprotein A. Why the coronary artery calcium score?
Yes, again, coronary calcium score at least will tell you, like, let's say in 35-year-old man with normal lab, but I have to learn to trust my instinct and the data. So I need to know where is the calcium scoring is right now, whether he's having 0 to 100 or 100 to more, so that I can start a statin therapy or some other test that I need to order, so I can order that test earlier.
Now, in a primary care setting, and of course, I see a lot of South Asian patients myself. Tell us about some of the things that I need to look out for in order to think about some of these tests that you're ordering in your own cardiology clinic. Any things in the history that would get my antenna up and look for potential early heart disease?
Okay, very good question. First thing, as we know, Dr. Kevin, we love to listen to the patient, what they're, telling the symptom. But besides the symptom, is there anything else going on in their family, in their life? Is there any stress going on? Is their family history have a heart disease or not? So again, we're gonna basic test that we do EKG, we do a lot of lab tests. In addition to that, we can do a little bit more tests like, as I said, lipoprotein A, apolipoprotein B. We can do high sensitivity CRP test, and then again look into that, their BMI, whether their BMI is fits there. We look into the ASCVD risk, whether or not it's a borderline or above the borderline, and what type of cholesterol panel or cholesterol thing we can do. We have to educate the patient about their dietary and lifestyle and all this thing. In addition to having, controlling all the other chronic issues if they have it, or managing how to, psychosocial issues. Those are the things that we need to address.
You mentioned apolipoprotein B, and that's a test that a lot of physician influencers mention a lot. Tell us a little bit about that specific test, apolipoprotein B.
Yeah. So again, those are the very new tests nowadays. And so we have to focus on that because lipoprotein A, apolipoprotein B, those are the two marker in addition to your bad cholesterol, LDL. So those are the three tests that if it's increased, then you know that, I guess that patient is going toward the wrong direction, means, going toward having a heart disease at future. So we have to act on something, very fast so that, this patient will not get any heart attack or cardiac event at near future. So again, those are the tests. And then sometimes we also look into the ratio. What is the LDL to HDL ratio? A lot of South Asian, I mentioned that LDL could be low or normal. However, HDL also normal or HDL could be low. Those are the things that we have to know, like what ratio they are standing so that you can manage those patients appropriately.
When it comes to statin medication, sometimes I feel like they have a little bit of a stigma attached to them. So many patients have talked to other patients on statins that have muscle aches, they
Mhm.
elevate their liver enzymes, and they're very, very hesitant to go on statins despite all the data that supports how they reduce the risk of cardiac events. So when patients are a little bit hesitant about going on a statin, even though it's indicated, what do you tell them?
Okay, very beautiful question. Yes, a lot of patients are hesitant to, having statin therapy because of the muscle ache. Sometimes they hear here and there in the social media that they might get dementia and all these things. But again, not everybody will get the muscle ache. If they get any muscle ache, usually they get proximal muscle ache, and usually it could be very temporary, and we can do maybe lower the dose. Maybe we can do some holiday break from the medicine, or maybe we can switch the other medication so that patient get adjust to it. So, but they have to know that in terms of getting some little muscle ache, for example, if I say, they will get used to it. They will not get all the time. And as I said, if someone get muscle ache and we can do all this, we can play all this role to eliminate the muscle ache. But they have to know that cardiac event is deadly. It comes only one time, and he or she might not even survive again. Who knows? So this is very important. So we can reduce atherosclerosis with that medication. So this is a revolutionary medication, and every day we have lots of other medication coming. If somebody does not want to take oral pill, and we can even again reassess the cardiac profile to see whether or not he or she can get injection every 1 or 2 weeks, or even Dr. Kevin, inclisiran, PCSK9 inhibitor, inclisiran every 3 or 6 months. Again, we can manage all this thing, especially somebody who has a cardiac event already, has a stent already. They have to have their LDL lower than 55. So to lower that thing, we sometimes can order the medication like Pata or Furlan or inclisiran even, in addition to statin therapy, so that we can lower the LDL less than, more than that, so it can be lower than 50%. So this is very crucial. So again, you talk to your primary care, talk to your cardiologist. If you have any muscle ache, then we can manage some other way. There are a lot of other options that we can eliminate that muscle ache or any little side effect that you can have.
We're talking to Monzur Morshed. He's a cardiologist, and today's Kevin MD article is Why South Asians in the U.S. Face a Silent Heart Disease Crisis. Monzur, let's end with some take home messages that you want to leave with the Kevin MD audience.
So take a message. First of all, I want to talk to my clinician that reassess your risk models. Traditional calculators often fail South Asian patients, and do not wait for symptom, because many South Asian with severe disease are asymptomatic or presently, and look beyond the labs. Consider waist circumference, lipoprotein, triglyceride, HDL ratio. Acknowledge the stress, legal trouble, immigration, divorce, loneliness. All this can play a role, and partner with community leaders. If you need to go to temple, mosque, churches, South Asian Association can be a great avenues for spreading awareness, and create safety in your exam room, because minority men often don't feel safe being vulnerable. And expand your definition of risk, and write and speak when you can. And also, I want to tell that heart disease is sometimes very silent suffering among minority men,
Hmm.
and they probably battling from their legal issues, broken families, unspoken fear, which can drive to heart disease. So we must treat the emotional wounds, not just the physical ones. So I will ask my fellow clinician that listen harder, ask deeper, treat the patient, not just the pathology. And because sometimes the most dangerous arrhythmia is heart that has been silenced for too long.
Monzur, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Thank you for having me.